This is Mary from the Rhode Island Wave here with Hematology Oncology Dr. Rathore at Roger Williams Hospital. He's been practicing for 21 years. But before we begin, I would like to thank you with us.
Thank you very much for having me.
What university did you graduate from?
I graduated from Delhi University. I came over to do my studies in the US. I trained in New York at SUNY, and then I moved over to Brown University to complete my Hematology Oncology training. After which I just stayed on and never left.
What made you want to become an oncologist or a doctor in general?
So it was always fascinating to be able to help patients, and coming from a third world country where diseases were not very well taken care of, it gave me the extra impetus to learn medicine. The biggest problem in our area was the lack of oncology training, and the best place to learn oncology is in the United States. So that's where I ended up.
What made you want to stay here?
So I stayed on in Rhode Island despite the high taxes, but essentially because it is such a welcoming place. I moved here, and after completing my training, I married, and my wife also joined me here. I brought up my whole family here, and I cannot dream of being anywhere else except Rhode Island. So I think Rhode Island has the advantages of everything that the ads will tell you, but I think the people here are special. They bond with you, and they become lifelong friends and colleagues, and I wouldn't trade it for anywhere else.
Nice. So what's a typical workday like for you here? What time do you go in? What time do you usually leave?
So we are an academic cancer center. We have a full-fledged teaching program affiliated with Boston University. So our work combines clinical work, which is about 2/3 of our day. 1/3 of the day is involved in teaching activities where we teach medical students, residents, and fellows. So typically we start off early with looking at the day's previous workup. Then we have a clinic schedule, usually from 8 to 2 or 3 o'clock, after which we do rounds in the hospitals when we are on. And in between we have teaching rounds for the fellows, or we deliver lectures, or we go to tumor conferences, which are spread out over the week. So all in all, it's a busy day, very challenging but fun also. Since we do beyond just patient care, we are able to involve ourselves in teaching, and I personally also involve myself in clinical research. So it ends up that we do a lot more than just taking care of the patient, and it ends up being a much more satisfying day for us.
And how do you stay on top of the advances in cancer medicine?
I think that is one of the toughest jobs to do, and I know that because I just recertified myself in oncology for the 3rd time, and I'm dreading because I'll have to do it again in 10 years. But coming back to the question, it is very hard to stay up to date. For example, there were over 100 new cancer approved drugs over the last 11 years alone. So staying up with that is very difficult. So one of the advantages I have is that my practice is restricted to a few specific cancer areas, which makes it easier for me to focus. But having a teaching program means we have to stay on top so as to be able to teach the next generation of specialists. And they also keep us on our toes. So it does involve a lot of work. We do go to conferences. We do participate in teaching activities. And we do a lot of CME, continuing medical education activities. So even though we are technically supposed to do only 40 hours a week, we end up doing quite a bit more, almost about 60 hours a week, trying to cover all these activities. But it is, at the end of the day, worth, because we can help our patients better when we accomplish these activities.
And what made you want to specialize in hematology oncology? And for those who do not know, can you just give a brief description of what it is?
Sure. So hematology is the study of blood disorders, both cancer of the blood as well as non-cancer disorders. And oncology is the study of cancer disorders, and I specialize in medical oncology, which is using medications to treat cancer compared to surgery, where the surgeons operate on cancer, or radiation, where radiation is used to treat cancers. I thought I'm not exactly going to be very skilled with my hands, so being a surgeon with those hours was not for me. I thought I could think better and utilize my services to patients across a wide spectrum of fields, and radiation was too narrow a field and involved a lot of physics and calculations. Again, not exactly which I would find very easy. But I think professionally speaking, when you combine hematology, blood disorders, and oncology, cancer disorders, you cover a lot of general medical care, specifically for both the young but most commonly for our elderly. Most cancers happen in the elderly after ages 50, 60, 70. That's where our population is growing. That's where everybody has parents at home who probably had cancer. And that's where I thought I could offer my services the best. And that's why I ended up with hematology and oncology.
Nice. And what makes Roger Williams Hospital different from some of the other hospitals in Rhode Island?
So, Roger Williams is a teaching hospital, which not all hospitals in Rhode Island are. That gives us a better level of being up to date and up to speed with the latest advancements and guidelines in cancer. However, we are also very nimble, and we possess all the core specialties and disciplines which deliver successful cancer treatments. So for example, we have hematology oncology, of which I am a part of, a group of 8 physicians. We have surgical oncology, or cancer surgeons specifically. We have radiation oncology, radiation physicians, and we have interventional radiology, physicians who do radiology but are specifically treating cancers. And this core group is supported by a whole network of cancer centers, such as this one in Providence, but other centers. Our real advantage is that we are small, we communicate very closely, and we have all these cancer teams which can expedite the care. So for example, a new patient here gets seen very quickly, within 2 to 3 days of the referral being made. And when the referral is made, take for example colon cancer, which is the 3rd commonest cancer, very common in the elderly. If there is a new colon cancer patient referred by the primary care, he will be seen by the surgeon and a hematology medical oncologist like me at the same time, at the same visit. His treatment is planned out then and there, whether he needs to go to surgery or receive chemotherapy, and that is launched within 1 to 2 weeks of being initially diagnosed. That fast turnaround time, that close working together in teams, usually is what is recommended by all the national organizations, and that's what translates to better outcomes. And I think we do it better or as good as anybody else in the neighborhood, and certainly in southern New England, that's for sure.
And what do you typically tell somebody that's just found out they've been diagnosed with cancer, and what type of support system do you guys offer them throughout their treatment?
So I think that's the most important question that I can think of answering today to reach out to the readers. Cancer can be a devastating diagnosis, and I remember my mentor told me cancer sucks. Always remember that when you're seeing the next patient. And having had that in my family, and I'm sure in everybody's family, cancer is really overwhelming, especially when it's a diagnosis that is unexpected. The first thing we try to do as a patient is tell them that there are options, that there's hope, that there's a lot of new advancements going on, and that there's a whole team of people working out to help them in their journey. We do not use buzzwords like fight and war and attack. That's not the mentality we like the patients to have. We like the patients to have as the journey that they're going to take with different doctors, nurses, pharmacists, social workers, dietitians, navigators, and other physicians who will help them navigate their diagnosis, their treatment, and their surveillance. I tell them that I'll be watching them like a hawk for the next 5 to 10 years to make sure that once we treat their initial cancer, that it doesn't come back. And that's what is most gratifying, is that at the end of the day, we build deep relationships with these patients. Granted, we are not able to help a lot of these patients, but every single one, I tell them, do not give up. There's a lot of options we can think of. There's standard options, and then there's experimental options. There's new research options we can offer them. So the first thing we tell the patients is, let's see what we can do for you. Let's see how we can help you.
And have you seen the survival rate of cancer go up in the past 10 years with new advances in medicine?
Right. So I think this is a very exciting time for oncology as a practicing oncologist. I wrote in one of my columns for the Rhode Island Wave that the most exciting development in the last 10 years has been the advent of immunotherapy. Now that was a graveyard for a lot of researchers for the last 20-30 years. Now immunotherapy is at the forefront and it's being applied in at least 20 different types of cancers, starting with the commonest such as lung cancer to the obscure such as thyroid cancer, for example. So what immunotherapy does is it activates the immune system to go and kill cancers. And the way it has done is has transformed the landscape. So take lung cancer, for example. That's the #1 cancer in the country. And because we use immunotherapy so effectively in lung cancer, that alone, that single type of treatment in a single cancer has brought down the cancer's death rate for the whole country. So that just tells us how much the impact of one treatment advance on just one cancer can end up shaping the outcomes for the whole cancer field. So similarly, we have a lot of new targeted treatments which we are using molecular testing to find mutations in these patients. So combined with immunotherapy and these new targeted treatments, we've really revolutionized how we treat cancer. Unfortunately, we still don't cure a lot of these cases. But for example, just to give you a hint, 10 years ago, the survival of stage 4 non-small cell lung cancer was in the order of 5 to 10% at 5 years. Nowadays, it's routine for 25 to 30% of the patients to be around at 5 years. That alone translates to about 20,000-30,000 more people living extra every single year. So in 5 years, we're looking at maybe over 100,000 more patients alive. When you look at the country as a whole, that's huge impacts. So yes, we've seen a lot of treatment advances, and I think we are going to see more and more coming down the pipe.
And are you seeing an increase of cancer diagnosis as the years have gone on, or has it been about the same?
So I think that also is an excellent question. We unfortunately do see an increase in cancers. As our population ages, we're seeing the old age cancers or the elderly cancers such as more lung cancer, colon cancer, breast cancer. However, we are seeing a lot of environmental issue related cancers. So for example, we have more lymphomas with use of pesticides, chemicals, Roundup, everybody is familiar with that in the news. And we are also unfortunately seeing some cancers much younger due to inherited cancers. So for example, we are seeing a lot of increase in colon cancers in patients in their 30s and 40-year-olds, which is a national phenomenon. And then there are some cancers which are particular to Rhode Island. So we see a lot of gallbladder and liver cancers here in women, which is probably among the highest rates in the country. We still don't know why. So yes, cancer rates are unfortunately increasing in certain areas. Overall, certain cancers are better, but they are still, because of our aging population, much more cancers that we are dealing with.
Yeah. And so since you're dealing with more cases, I'm assuming that there's probably an ongoing demand for oncologists in the medical field.
Right. So the increasing demand is obviously because of more cases, but the good part is also that we have patients living longer, more of them are cured. So as a result, they need to be taken care of for much longer. So we are expecting nationally oncology shortage by 2030, 2035. So one of the goals is to increase training in oncology and also increase training for mid-levels such as nurses, nurse practitioners, physician assistants to help with the increasing wave of cancer patients, not only new ones, but those who are surviving much longer. And I think we need to really be hard at work in the next 10-15 years to meet this challenge.
Yeah. I mean, I know a lot of people that are going to the medical field mostly for nurses, but what type of incentives would be to be an oncologist, and what type of personality traits would make a good oncologist? Because I know that it is a very difficult job.
So being an oncologist is not easy. Being involved in the training of oncology physicians, we are just in the middle of interviews for our next batch of fellow trainees, for example. You have to have a certain kind of fortitude to be able to tolerate the sadness, the fatigue, the dizziness, the weakness, the life which is kind of spent in front of your eyes, and you have to have the moral support that you have to offer these patients. Plus you have to be their guide, and you have to be their treating physician also. And after a while, there's a high amount of burnout also when you see so much death and destruction and so much of promising lives being cut short. So as a result of that, I always tell patients that you have to have a strong fortitude. You need to be very dedicated to making their lives better. The good thing is the newer generation of trainees all are very excited to join. And the other thing we've seen is that the number of women who are training are actually outnumbering the men in terms of the newer trainees, which is a really excellent development. And all of them are excited with the new medical advances in oncology, which is another reason. Before, oncology was a field where you helped very few. Most of the time you just helped them as they declined. Nowadays it's a bit of a role reversal. With so many new treatments, you can help a lot more patients for a lot longer, and so more and more people are excited to go into this area. And as a result, I think we will be able to meet the challenges. But yes, you do need a special kind of fortitude to be able to hold your hands with the patient as they go through this difficult journey.
Yeah. So what other things would you like the Rhode Island Wave readers to know about your program?
So our program is comprehensive in the sense that it covers all major cancer care disciplines. Besides, we have the state's only bone marrow transplant unit. Otherwise, most patients who need that service would have to go to Boston or New York for that, or to Yale. So our program is multi-site in the sense that we have two major centers right here in Providence and East Providence. Plus we have satellite offices in Lincoln, Johnston, Cranston and East Greenwich. So we cover a fair bit of the population areas in the state. Our physicians are all Boston University faculty. So we have teaching programs as well as clinical programs. Plus we have a cancer research clinical trials office, which I also head, and that provides newer clinical trial options for the common cancers that we see. So for example, we are opening a national trial in lung cancer, which will be not available to anybody south of Boston. And that I believe will be a new option for our patients with lung cancer. So similarly, our physicians are also involved in specific trials. We have some immunotherapy trials ongoing. We have surgical oncology trials ongoing. And with these trials, along with our effort at quality and multidisciplinary care, we can take care of the whole patient, not just the disease. I think that's where we excel at, and we've been doing that for the past 20 plus years. And I'm proud to say that we are making headway every single day and trying to help these patients.
And how has COVID changed the way that you guys have functioned here?
So COVID has affected our patients in a number of ways. So during the first and second waves, a lot of patients did not venture out. Screenings dropped and their visits also dropped. So that was doing them a disservice. Fortunately, we were able to quickly convert to telemedicine, but that's not exactly the best for cancer patients who need to be actually examined while they need to come in for their treatments. Also, some surgeries got slightly delayed, but after the initial 2-3 months, we were back on full steam. However, as you know from your experience, cancer patients are immune compromised, so they are especially at high risk for complications, and especially lethal complications. We know, for example, that if cancer patients get COVID, they're probably 3 times more likely to die from it than the average patient who does not have cancer. So that has been extremely challenging and stressful. We've been trying to get our cancer patients very vaccinated, but unfortunately the vaccines don't work very well in cancer patients. So that is a bit of a half step forward, but only a half step. And so we continue to progress with this. We've had some outbreaks here, just like every other place, where our staff have been involved with COVID, getting sick, but I think they've all stepped up and continue to get the cancer center going. And we are having 20,000 patient visits a year in our cancer program between all 4 disciplines, and I think we are growing, which is a good thing for our institution, but unfortunately it also means that there are more patients with cancer.
And from being a cancer survivor myself, how long do you usually stay with your patients after they have recovered from their therapy?
So as you know from your experience, We usually recommend all guidelines to follow patients for up to 5 years at least. However, a lot of patients develop a strong bonding, and we do long-term follow-up on an annual basis for up to 10 years or 15 years. Some cancers, as you know, can come back even longer, 10, 15, 20 years later. And so annual follow-up, which we do as part of their complete team along with their primary care and the other specialists, is often considered. There are some cancers which, once they are cured, almost never come back. And so those patients we stop at year number 5.
Well, I know you also write for the Rhode Island Wave. You've been with us since we started in May. We have missed you for the past few months, but I'm happy to hear that you will be coming back. What type of articles should people be looking forward to?
I think I have written enough on COVID, but unfortunately COVID is not leaving us, so we'll try to look at the impact of COVID, especially on cancer. I will also explore the physician side of things, of when the physician is the patient, how are things different. I will also look at certain hidden figures or persons who in Rhode Island medical field are doing very instrumental key work but are not in the newspapers or in the CEO offices. So certain warriors who deserve more recognition for their work but are well known in the physician community but not out in the lay community. And I think their work needs to be recognized also. So I hope to contribute on a more regular field after this summer break and reach out to my colleagues again. Thank you.
Well, lastly, what do you do to keep yourself from getting burnt out? Do you ever go and visit your family in India, take vacations, have hobbies?
Certainly we have hobbies. One of them was to start writing, which I always had not had an opportunity, and I want to thank Rhode Island Wave for giving me that opportunity. I like to travel, which unfortunately has been difficult in COVID. With my 2 children, they have prodded me to become a little more physically active, so hiking is something that I've picked up now with my family. And yes, I do like to travel back home to my family and friends in India, which has been limited because of COVID again and the travel restrictions. And certainly I love to hike around southern New England also, because there's so many beautiful areas to hike and learn the topography of this nice northeast that we live in. I can't wait for fall with all the new colors changing, though my wife doesn't agree with that. She'd rather have summer all year long.
Nice. Well, it was a pleasure speaking
Likewise.
with you, and thank you so much for taking the time to talk with us.
It's my pleasure, and again, shout out to all the cancer survivors out there who are by their doctors wherever they are, and again, good luck with everything. Thank you.